On this next episode of, I like saying episode because it means we're going to be around a while, Dr. Raban. This is exciting. Of Plastic Surgery Uncensored. We're actually going to walk people through an actual consultation. We have a young woman who's going to come in, and she's going to let you walk her through the entire process. And she's not an actress or a celebrity. She's a regular person that wants regular things that's actually going to be a patient. So hopefully become a patient. So
I'm excited about that, especially, I think people don't know what to expect. And the information I get often is, wow, I didn't realize I needed to know all this. So I look forward to it.
Great.
All right. So Melissa, thank you for coming. What we're going to do today on our podcast, which is Plastic Surgery Uncensored, we're going to do something a little bit unusual, and I think quite helpful. We're going to actually do a consult together. You and I just met, and you were referred to us by a good dear friend, and I think it's kind of useful for people to get an understanding of what exactly a consultation is like, because what I often hear when people come to the office and they do a consultation and say it's their third or fourth or fifth consult, often I hear, wow, that's pretty intense. I didn't really expect all of that information, which suggests to me that they're getting much less information in their traditional consults. And I think that's sort of the setup for the disasters that occur, because at the end of the day, patients are inquiring to have major work done. And if you meet a guy and you talk to them for 10 minutes and then all of a sudden you expect that to translate to amazing outcomes, it shouldn't surprise you that so many people are unhappy. So what we're going to do together today is I'm going to actually do a consult shy of the exam, because you and I examined you earlier. We're going to kind of go through A to Z of our consultation. So I'm going to open it up with you, and as I always do, and say, hey, hi, nice to see you today. And what brings you? Why are you here? What's going on?
I have very large breasts because I had a breast augmentation when I was in my early 20s. Didn't think about what it would be like 20 years later when you put on 30 or 40 pounds. Now they're very large, and it's been uncomfortable on my back for some time. So I'm looking to get a reduction, a lift, because I do still want perky breast, just smaller breast. And I'd also like to get some work done on my tummy.
What's going on with your belly? What's bothering you with your belly?
Just fat there that I never seem to get rid of, no matter how much I work out.
Okay, so let's back up a little bit to your breasts. And you kind of did what a lot of patients do, which is not uncommon, which is you came in and you said you have large breasts. That part I got. And you said that you needed a lift. And I'm assuming you either read that or you've heard that or you assume that. So why don't we start out by describing what's going on with your breasts? So I'm assuming your breasts are large. That I understand. Shape-wise, is it that they're sagging? Is it what aspect of your breasts, what makes you think you need a lift?
My guess that I need a lift is because they're sagging over time.
Okay, so sagging means you have a lot of contact between your breast and your chest, and the nipples are pointing downwards. Okay, great. Yes. So that's a great start. So I'm going to ask you some questions here, and we'll go along. And some of these things are personal, and I think it's really courageous of you to kind of be willing to do this on the air, because I think it helps other people understand what's considered maybe a customary experience. So, of course. Melissa, how old are you?
I'm 44, almost 45.
Awesome. And how tall are you?
5'3".
Great. How much do you currently weigh?
148.
Got it. And what's the most you've ever weighed in your whole life?
Around 168.
Okay. So when was that 168? How long ago was that?
I've probably lingered between like 155 and 168 for like 3 years, but I was up to 168 a few months ago.
Oh, okay. Well, good. That means you're at 148 now, so that's 20 pounds. That's excellent. And how did you end up losing that 20 pounds?
I've been working with a personal trainer, really hardcore.
Okay, great.
4 times a week, hour and a half sessions.
Congratulations. So you actually did what it takes, which is you're actually doing the patients are under the impression, and it's incorrect, that if I'm going to a plastic surgeon, why the hell do I need to lose the weight myself? That's the whole reason I'm paying for it. And that couldn't be farthest from the truth. As a matter of fact, at 5'3", and I examined you, and 148, while that is way better than 168, you're still off from your not ideal weight globally, because there's no such thing, but your ideal weight for surgery. And I'll elaborate to tell you that. But one thing you have going for you is that you're definitely on the right track. So that 20 pounds you lost, I think, has made a significant improvement. What's your so-called goal weight, not ideal weight?
In my mind, around between 130 and 135.
Okay, so 130, 135, that's not too far away, and that's realistic. I think goal weights are very important for patients. People always come to me and say, oh, I just can't seem to lose weight. You don't understand, Dr. Bond, my metabolism. Your metabolism what? You don't have any different metabolism than anybody else. And, you're either eating too much or you're not doing enough exercise or you're doing both. And the truth of the matter is that you can lose the weight, but it's very important to have realistic goals. And I think at 130, 135, when you're at 148, it's very doable. And you've already demonstrated you can do it. So I think that's a great number for you. I think it's really important not to pick some number. Like I was, for example, I hear all the time, I want to be 125. That's what I was before pregnancy. I want to be 125. That's what I was in college.
Right.
While that's great, and some people do it, it's not realistic for most people because you are not the same genetic human being you were. The reason why it's very important to make sure that you don't say those things is because you set yourself up for failure. Because when you're not getting close to that, which is probably unrealistic, you get discouraged. And a lot of this is emotionally taxing. So I think that's an appropriate ideal weight. Do you take any medications on a daily basis?
I take Synthroid because I had half of my thyroid removed, and Wellbutrin.
So other than the hypothyroid, you take the Wellbutrin for anxiety or some depression. What do you take it for?
I take it for anxiety, and I've been on it for a few years now, and I've started to wean down, but I don't know that I'm ready to go completely off of it.
Got it.
Because things are good.
Okay. Yeah, I think there is a minimal dose that's probably necessary. Any allergies to medications?
No, but I am very sensitive to the anesthesia. I get really sick when I wake up.
Does that mean sick, meaning nausea and vomiting?
Yeah.
Meaning, okay, yeah. Supplements, fish oil, flaxseed, chia seeds on a daily basis.
I take a lot of supplements because I just did a lot of work with my naturopath. And so I had a lot of hormone imbalances and vitamin deficiencies and problems with properly digesting the food. So I'd have to give you a list.
No, great. So what I want you to realize is great. Continue your supplements. When it comes to your surgery, you want to be off of all those supplements because some of those supplements will make you bleed. And so patients that, I had a lady who was, had a breast dog, and then all of a sudden, a day later, she started bleeding, and we couldn't figure out why, and she was taking extensive amounts of chili pepper extract. And who the hell has heard of chili pepper extract? Well, guess what? Apparently somebody has, and it makes you bleed. So we really want to make sure that you'd be off of that.
How long do you go off of them before?
2 weeks off before, and then you can go back after a week.
Okay.
Other than the partial thyroidectomy, have you ever had any other surgeries?
Just the breast augmentation 20 plus years ago.
Got it. So let me ask you a few questions because that's really important. The breast augmentation was saline or silicone?
Saline.
Got it. Was it below or above the muscle?
Below.
Below. And do you remember roughly how many cc's it was? Was it 200 cc's, 400 cc's, 500 cc's?
I think it was around 350.
350. Did they enter through your belly button, through your armpit, through your crease, or through your areola?
Areola.
Got it. Okay, awesome. You smoke?
No.
You drink?
Very, very occasionally.
Okay. Recreational drugs?
No.
What do you do for a living?
I'm an attorney.
Ooh, okay. That changes everything. Pregnancies?
None.
Family history of breast cancer?
None that I'm aware of.
Have you ever had any breast masses or lumps or suspicious things that needed a biopsy and ultrasound for any reason?
No. My mother's had a couple, but that's it.
Okay. When was your last mammogram?
Probably a year and a half, 2 years ago.
Okay. So you're going to do for another mammogram. I'm really big on mammogram and breast health. My sister had a double mastectomy at 42. We live in the greatest country in the world. You should be getting a mammogram. I'm going to go out there and say every year, even though the maybe the national recommendations are every other year or whatnot. Right. I just think it's like one of those no-brainers. It's like pap smears, colonoscopies, things that we can actually check. Why not? You can't check if you get pancreatic cancer.
I am due.
So for sure, before your surgery, you're going to need another mammogram. Okay, so let's talk about size. You're 30, 36D, 36 double D. What do you wear?
I think I'm like a triple D E, depending on what kind of bra I'm wearing.
Got it. And then, so this is a really big part of this. So breast, your goal in breast is for your breast to be smaller and better shaped. Right. So there's two components. So assume for a moment that your breasts have amazing shape, like they were maybe when you were 18 or maybe yet you never even had them. Size-wise, do you want to be slightly smaller or significantly smaller? And if so, what size do you think you want to be?
I think significantly. I think I'd like to be a full C.
Okay.
But I would trust your opinion about what
makes
fits
sense.
My body
I'm going to
size.
tell you that when it comes to sizing, particularly smaller, it's very important to pick something that still looks good, not something that makes sense to you or makes you emotionally feel like, wow, I've made it smaller. Because remember, at the end of the day, your chest is still as wide as it was. And so if you make it too small, it may be a little bit flat, and we'll get into sizing. Okay. Got it. Okay, so that's great. So normally at this point, in this juncture, we would what? We would do an exam. I would examine you, and I've already done that. And so for our listeners, I'm going to describe your exam a little bit so that when I tell you what our game plan is, it kind of makes sense to you. So when it comes to your breast, you have very full breasts, of course, because you have the implants in place. Your implants are soft and they're mobile. Why that's important means that you don't have not developed very strong capsular contracture. So many women who get implants, when you get an implant in your body, whatever that implant is, a implant of your pacemaker, prosthetic knee, or heart valve, your body is going to protect you from that implant, foreign material, and it's going to make a shell around it that's called a capsule. So every woman in the world, and I think there's 25 million plus women, have capsules. The question becomes is that capsule soft or is that capsule hard? Okay. When the capsule is hard, meaning it's very reactive, not dangerous, just thicker, we have to address that capsule as well. In your instance, your capsule is very soft. That's why your breasts seem to be very mobile and move. The issue with your breasts, of course, on an exam is they're very large. I do agree for your frame. Your breasts are large. And you had said to me earlier, you have a lot of back pain and neck pain, which is quite common. Additionally, there's sagging tissue. What does that really mean? It means that the nipple is below the crease. It means a substantial amount of your tissue is below your crease and also touching your chest. So that's what we describe when we say a breast is sagging. In addition, your upper pole, in your instance, the upper pole, which is the area on the chest area where everyone's looking for fullness, you have too much fullness. Your implants are sitting up high and they're filling up the upper pole. So we really want to create a better shape for you. Okay. So we look at your breast and I say you have shape and you have size. Also, your left breast is a little bit larger than your right breast. And part of that might have been your own anatomy and part of that be the implants that were selected.
Yes, one was large, one was smaller in the beginning.
Great. So shape and size. When it comes to breasts, which is more important, shape or size?
I think shape.
Shape. 100 times out of 100, it's shape. So that doesn't mean that you got to ignore size. It just means you got to start the conversation leading with the thing that's most important. Many times doctors start this conversation about size, and then you build the shape around the size. Huge mistake. We talk about the shape and then we build the size around the shape. So shape means what? Means that we need to either do, as you had correctly said, you need to do a lift or you need to do a reduction. What's the difference? A lift is a skin-only procedure. We remove skin. That's it. Okay. A breast reduction is a skin plus tissue procedure, meaning we remove skin and some breast tissue. Okay. People assume a reduction is like massive breast made smaller. No, any amount of breast tissue I remove is technically called a reduction. And in your instance, in an effort to make your breast smaller, we will change the implant size, but we'll also take out some breast tissue. So you're going to get a reduction rather than a lift. Okay. They will look the same on the outside. A reduction has a lifting effect, but we also remove a little breast tissue so we can really make your breast the right shape and size. So reductions and lifts, let's for the time being just call them synonymous. To the patient, what really matters is what?
Shape.
Scars, right?
Oh, that too,
yes. Scars. So patients are always most worried about, oh my God, but I'm a young girl, I'm not married, or I'm married, and I don't want to have a bunch of hideous scars. People go online, they read reviews, they see how awful some scars can look, and the problem is you're exchanging one problem for another.
That's my biggest concern.
Of course. So the incisions that we use for a lift or a reduction come in 3 flavors, I call them. Okay. The donut, the lollipop, and the anchor. So that means that, and you can see, but our listeners cannot, it means the incisions around the areola, all the way around, that's a donut. It's around the areola and down the middle of the breast called a lollipop, or it's around the areola, down and across the base called an anchor. Right. So, of course, women want the one with the least amount of incisions. Yes. But that is not how this game works. It does not work based on what you want. It works based on what you need. So what do you need? It's based on your measurements, which means the more sag you have, the more skin you have, the more incisions you need. Okay. So based on your measurements that we did earlier, and actually for the most part, most patients, you need an anchor. There is no way around it. Okay. Do you know how many revisions I see every year where patients come in and they had a surgery done, they didn't want the anchor. Their doctors agreed that they would not do it even though they thought it was the right thing. And they're here now for a revision because the shape is inadequate. So I have a very strict philosophy: either do it right or don't do it at all. Nobody wants to give you a bunch of incisions you don't need, but I know that what you're going to hold me accountable for is the shape.
Okay.
And we need this anchor in order to get it done.
I had a friend that just did exactly that. She's built like me and had without the anchor.
Right.
I don't know how that's going to last long term.
You watch and see what happens. So now we talked about the shape. Now we got to talk about the size. So what we need to do is we need to remove and replace your implants. Can I get rid of my implants completely? Probably not in your instance.
Okay.
Why? Because if I remove them, there's a good possibility you don't have enough of your own breast tissue. If I could remove them and build you a breast that's beautiful, of course you'd rather have a breast without an implant. Who the hell wants an implant if you can get the effect? What size breast were you before you had it? A B?
I was B. Yeah.
Okay. So a B is not enough breast tissue, especially now that you've had an implant in 20 years. That implant pushes on the breast tissue and actually makes it less tissue than you had when you started. So we're going to remove and replace and change the implants and decrease the size. Okay?
Okay.
The question then becomes is what's the right size? That's the elephant in the room, right? So first issue is that you don't even know what size implants you are right now. That's issue number one. And second issue is that how's your doctor going to figure out? So sizing is a big, big, big part of what we do when it comes to any breast surgery, breast aug, breast reduction, breast whatever. So traditionally what happens is that you'll tell your doctor you want a C+. He'll nod his head and be like, okay, got it. And then what happens? You go to sleep, you wake up, and you pray that he picked the C that you like. Because you and I both know C means nothing because it depends on the bra, your chest diameter. Is it a 36C, a 34C, Victoria's Secret, padded, not padded? So I don't do anything based on that. Too risky, too much variability. So what I do that's completely different is you're going to end up going through let's say you decide you want to do this. You're going to go through a bunch of photos. You're going to pick a bunch of front photos from the gallery, and you're going to say, I really like these two pictures. These are the size of breasts that I think look attractive.
Okay.
These two over here, I like them, but they're a little too small. And these two over here I really like, but just way too big. So what I do that's distinctly not different than anyone else, but very unique, is that I don't go into the surgery with a set of implants ready to go. Because what technically your doctor's going to have to do is he's going to have to guess, right?
Right.
So you're, let's say, a 350 saline. He's got to have to say, is it going to be 250, 220, whatever. He's going to have to bring those implants, and he's guessing. I hate guessing because guessing leads to error. So I have a closet. I open that closet, and in that closet is every single implant the manufacturer makes, from 100 to 800 cc's, moderate profile, high profile, smooth and textured. So I have everything they make.
And I don't know the difference between any of those.
That's true. You don't. But the point being is that I have everything available to me, so I don't have to worry. And this is the important part. For every single implant that I have an exact sterile replica called a sizer, physically another version. So essentially what I do is I take out your implants, and then I start to downsize your implants with actual implants, and I what's called tailor tack or staple your lift over the new implant and sit you up probably 5 to 10 times. And in that process that's how I figure out what size you should be, because I'm looking at the photos you selected, and that's the size you'll be. Will that be a C? I have no idea. How many cc's will I be in advance, Dr. Raban? I have no idea. Nobody can do what you're asking them to do and tell you in advance all the moving parts, because it's going to depend.
Okay.
So if your surgeon is not willing, because this is a willing thing, to take the time to do all of these gymnastics I just mentioned to you, because it's very time consuming and it is a pain in the ass, then you will get an okay result. If you want an outstanding result, symmetry, the right size, beautiful shape, blah, 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 you need someone to take time. And time is very undesirable or unfavorable when you're paying by the minute. Okay? So size, we're going to downsize. You're going to go through that photo selection. Next, we have to pick a type of implant. You're currently saline. You have two options. You have saline and silicone.
What's
the first question you're going to ask me is, well, I want the one that's safe, Dr. Raban. So based on today's extensive research, and I'll get to you about other things, their safety profile is the same.
Oh.
The next question you're going to ask me is, I want the one that's softest, most natural. Well, it turns out that the silicone implant is softer in nature than the saline. The saline implant is a water balloon of sorts. It's an implant. It's a silicone casing with water filled in, saline. And the silicone implant is the same casing with gel put in it from before. So from the standpoint of feel, your breasts, as you notice, feel a little bit firm. Like if you go to hug someone, they kind of know that they're there.
Yes.
The silicone implants are more collapsible and softer. There's a whole discussion, which we'll get to at a later time, which is, but I heard silicone causes you these diseases, and there's Facebook groups, et cetera, et cetera. But we're going to defer to that a little bit later. For right now, we're going to refer to the current data and research.
Okay.
Safety the same, softness, I think silicone is softer. You can have either of them. I don't care. My own preference is I think the silicone implant is a superior implant in terms of its functionality. But again, either will work. Okay. So we talked about removing and replacing them. We talked about possibly changing them to silicone. You'll figure that out. We talked about how we're going to do the sizing. Okay. We talked about the anchor reduction.
Okay.
So what you're essentially going to have now, so I'm going to give you a little conclusion here, is you're going to have an anchor reduction, remove and replace, exchange of your implants to a smaller size. The size is going to be determined not by a letter, but by a cosmetic outcome.
Okay.
And the reason why that's important is you have a width to your chest. You have actually very broad chest, right? Very wide.
Yes.
So if I imagine a small implant in there, you can start to understand three-dimensionally that that's going to be flat.
Right.
So you need a minimum amount of implant to make the breast round in order for them to be pretty.
I definitely want the round fullness. So.
Okay, so that makes sense, right?
Yes.
Okay.
So now that we've covered, the above the waist, above the Mason-Dixon line, next we're going to talk about her concerns below, the belly situation, the abdomen, all of that good stuff. You are listening to Plastic Surgery Uncensored with Dr. Roddy Raban on Revolver Podcast.
Let's change gears and let's talk about your abdomen. So I examined your abdomen, and your abdomen is fairly good, right? You have a nice smooth abdomen in that you haven't had any children yet.
No.
So you don't have a lot of stretch marks. You also don't have a tremendous amount of loose skin, but you have some loose skin. And you have a little bit of fat, as you said, sort of the stubborn fat that's in your abdominal wall.
Yes,
okay?
never seems to go away.
Right. You also have a little bit of fat in your love handle area or around your hips. That area is sort of where most women collect the fat.
Yes.
The question then becomes, all right, what are my options? Option number one. Oh, well, let me back up. There are only two tools in my box. I can only grab two tools. I can suck it out or I can cut it out. That's the only things we have available today.
Okay.
Suck it out means we can remove the fat. Cut it out is we can remove the skin. So in the suck it out category, we can do liposuction. We can liposuction your abdominal wall. That sounds exciting. People love the word of liposuction. So what will that do? It will get rid of the fat, but what will it not do?
That I don't know.
It will not get rid of the skin.
Oh.
That's not so fun. What happens to your current skin that you have?
So I'm going to have sagging skin.
You're going to get looser skin. People don't think about that part. So the problem with liposuction in general is when you remove the fat, even though lots of doctors would like you to think that if you do smart lipo, laser lipo, there's a lot of lipos. They all have different names, that they can tighten the skin. They can tighten the skin a little bit, but they almost invariably leave irregularities to the skin.
Okay.
So the idea that you, at 45, are going to have a abdomen that's flat and smooth and tight from liposuction is not realistic.
Okay.
If you just do liposuction, you will have less fat and irregular skin, guaranteed.
That's not good.
No, so that's not ideal. Next way to remove fat is things that are like non-surgical, like cool sculpting or radio frequency, etc. I'm going to say for the most part, they're not going to be successful for what your abdomen looks like.
Okay.
So that takes care of the suck out category, right? Now we're at the cut it out category. That's all the tummy tucks, the mini tuck, the full tuck, the this, that, the other. Essentially what those are is an incision in the groin area through which you lift up the skin, look at the abdominal wall, remove the excess skin and fat, and close everything up. The advantage of that approach is that any excess skin you have, which you have a little bit, will go away, and your abdomen will be tighter. Also, there's a little bit of fullness to your belly muscles, and we can tighten those up as well, even though you haven't had kids.
Okay.
The downside,
scarring.
There's a big scar, and that scar is people like to call it a mini or whatever. It's a scar, and so it really depends on how you heal and how well your closure is, but it's definitely an exchange. I think as you lose the weight you're trying to lose, you're going to be moving in that direction.
Okay.
In other words, when you were at 168, you were leaning on the suck it out category.
Right.
Tight skin, very full. As you're losing weight, have you noticed the change in your abdominal skin?
Yes.
What are you noticing?
It's just sagging more. It's just
Right.
kind of there.
So it's deflating.
Yeah.
So it shouldn't surprise you. Now, when you're 20 and you lose 30 pounds, your skin hangs tight. When you're 40 and you lose 20 pounds, not as much. So I anticipate when I see you again in 15 pounds, you're going to be more in that direction. You're going to have to make that decision on your own. Okay.
Okay.
Your love handle area is easy and straightforward, and that's liposuction. Why can I liposuction my love handles and I can't my abdomen? Because your skin on your love handles is much tighter and thicker than the skin on your abdomen. Is it not?
Yes.
It is. So it will do well, but not so much the abdomen. A lot of people go in quick and dirty, get the liposuction. They're ecstatic the first 9 months. It looks amazing because it's swollen. And as the swelling dissipates, year 1.5, then 2, 2.5, then they show up with all these kinds of irregularities and dimples and a little loose skin here. And your whole goal is to wear a bikini. You're a young, beautiful woman. I don't know that it'll be an exchange that I don't know that you're going to be happy about.
Okay.
Okay, so keep that in mind and keep that.
That's something I never thought about.
Okay, but does that make sense?
It does.
Can you not see your skin's kind of a little loose now?
Yeah.
Can you imagine as you lost the 15 pounds, what direction your skin would go? So it makes sense.
Yeah.
Okay, so that takes care of the abdomen. Now let's talk about recovery. So pain. So the pain, as far as the breast is concerned, I say is moderate. Okay. When it comes to the abdomen, if you end up doing a tummy tuck, which I anticipate you probably will move towards, I don't know yet till I see you, the pain is more moderate. It's more like a C-section. All these things are tolerable, but they're not nothing.
Okay.
And again, people are going to lead you to believe you're going to have a weekend mommy makeover. Not going to happen. So you need to give yourself return to work. Breasts, 7 days. Abdomen, 2 weeks.
Okay.
Next question, can I do them together? Absolutely. You do them, they're called a mommy makeover.
Okay.
The amount of you can have, I don't want to say as much surgery as you want, but the reality is it's not based on how many procedures, but based on your overall health.
Okay.
If you're a healthy young woman without any medical problems, you can tolerate, or your body will be just fine with multiple surgeries. If you're an older, not healthy person with diabetes and high blood pressure and I had a stroke, then you should have no elective surgery. That's how it works. So you doing them together is not an issue.
Okay. I didn't know if it were put me prone to more complications.
Well, theoretically, if the complication rate with the breast is 2% and the complication rate with the abdomen is 3%, then the complication rate is 5%. But you're doing a bunch of surgeries that should have a low complication rate. So doing them together, while the complication rate is slightly more, is way, way more important than one recovery, one anesthetic. You're a lawyer. Are you going to take time off of your job twice?
No.
Are you going to disrupt your life and not go to the gym? So it's a very big deal when you do these surgeries, and you're unlikely to do them more than once.
If I work from home, so what's the likelihood that I will be like up in bed on the computer?
There you go. So 7 days, 7 days from the breasts,
Okay.
you could go back to a desk job.
Okay.
2 weeks from the abdomen, you can go back to a desk job. Together is 2 weeks.
Okay.
When can I go back to the gym? 6 weeks.
Okay.
How many follow-ups? Usually we see you 5 times, 1 week, 2 weeks, 6 weeks, and 6 months. How long does it take in the operating room? The breast reduction with implant and removal. It takes me 4 to 5 hours. When you see a doctor and they're telling you they're going to do a breast lift and implant, an anchor on a large breast like yours, and they're going to do it in 2.5 hours, that should give off a lot of red flags. If you want your breast to look symmetrical, have beautiful scars, and be the right size, that takes time. Time means sit you up, sit you down. That's the wrong implant. Her left one's bigger, et cetera, et cetera. So when it's done quickly, the question you should ask is, how is that possible? Could I ask you to make me a mural in 15 minutes?
Absolutely.
How about quilt me a sweater in 5? It's just not possible. Your abdomen will take an additional 3 hours. Wow, 8 hours.
8 hours.
Yes, that's called a mommy makeover. It's done under general anesthetic, and I always use my own team of anesthesiologists. So it's very common for patients not even bother to ask about anesthesiologists. I like the doctor. I'm sure his team is good. Not necessarily. So I use my own crew, my own core of anesthesiologists. They put my mom to sleep. They put my niece to sleep. And they're all anesthesiologists as opposed to nurses and nurses. Is there anything wrong with having them? No, but you should ask.
Okay. That's something I never thought of either.
Right. It's done in a Medicare facility. In other words, I do it as an outpatient, like almost everyone. but there are different levels of accreditation. You got to know, is it done in the office, in the back? I can put you in the back of my office in some little rinky-dink place and do it, or I can do it in a legit certified facility where we do orthopedics and other heavy-duty surgery. So you want to just know that the facility is up to par.
Okay.
Okay. All right. The last part. What are my risks? Bleeding, usually very rare. Infections, equally rare. Number one concern, scars. So listen carefully. 50-50.
By looking at my prior scars, does that give you any indication of?
Yeah, of course. Like if you had your scars are very faint and they look good, so that's a good sign. But 50-50. So 50% of it is your DNA.
Okay.
What will Melissa make? Thin, thick, dark, raised, wide, brown, red. That's your DNA. That's what your body is prone to make. The other half is how are you closed? Who closes you? Is it multiple layers? Is it whip stitch? Is it glued? Is it stapled?
Oh.
So you have no control over yourself, but you do have control over your closure. So let me digress here.
Okay.
I close everything myself. The entire right anchor, the entire left anchor, and the entire abdominoplasty. And while that may seem like, yeah, sure, that is not the norm today in cosmetic surgery. Almost ubiquitously, the technician or a junior or an assistant will help close, if not close all of it. The closing part of the surgery is the time-consuming, labor-intensive part that nobody wants to do. And so when a surgeon says, I'm doing your tummy tuck in an hour and a half, or I'm doing your breast lift with implant or breast reduction and implant in 2.5 hours, how is that possible? They're tag teaming it.
That's scary. I would have never thought to ask that.
So you got to make sure and ask who's closing. Asymmetry, 100% guarantee that your right and left breast won't be the same. No way possible. But they'll be much closer than they are now because your asymmetry is noticeable. Loss of sensation to your nipple. How's your sensation now?
It's pretty normal.
Right. So how does the sensation occur? The loss of sensation. It has actually nothing to do with the lift or the reduction. It has to do with a nerve in your armpit. So when you pick ginormous implants, the nerve gets impinged. So we're not going to even be near your nipple, your nerve. So that's going to be great. We're downsizing. Okay. Necrosis of your nipple. Sounds awful. What does that actually mean in English? Means death to the nipple. Blackened, gangrene.
Wow.
So when you do a breast lift or a reduction, your nipple is going from down here, right, by your crease, and all of a sudden, magically, it's up to the middle of your breast.
Okay.
Like, how did I do that? I didn't cut it off and glue it on. It's not a sticker. So I have to cut certain areas of your breast tissue and release and rearrange the blood supply. In that process, that nipple is going to get less blood supply. So if you're a smoker or you're a diabetic or you have heart disease, the risk of your nipple not surviving the journey goes up. In a healthy person like you, it's very infrequent, but it is something you should be aware of.
Okay.
Rupture. These are implants. They can rupture. The rupture rate, thank God, with new modern day implants is quite small, very small, probably less than a few percent over 10 years. So the manufacturing of these implants has come a long way since the 70s and 80s. And last but not least is something called Capsular Contracture, which I touched on, but I'll elaborate again. So I put an implant in a body and the body knows that that implant doesn't belong there. It's a foreign material, like a pacemaker, prosthetic knee, etc. And your body will protect you and it'll make a shell around it. And that shell is there to help you and it's very thin and you never know, and yours happens to be very thin. Some women, they make a thicker capsule. Their body thinks it's doing them a favor and it gets really robust scar tissue. It's not dangerous. It's not going to kill you, but it will change the shape of your breast, make it look a little bit oblong or higher or harder.
Okay.
And if that happens, the only solution is to cut that scar tissue out. So the fact that you haven't had it doesn't mean you won't get it again.
Oh, wow. I was going to ask you that.
Right.
Okay.
So it's less likely, but it's not impossible.
Okay.
So capsular contracture is possible. All right. So that's your consult. It's a lot of information. It's not just because we're on a podcast. This is what it should be like. This is what you should be hearing and getting for everything that you're doing. Oh, I forgot to tell you one thing. Your liposuction of your love handles. Irregularities, and irregularities. The number 1, number 2, and number 3 issue with liposuction anywhere is irregularities. You are literally removing fat piece by piece. So imagine you build a highway out of cobblestones as opposed to asphalt. So there's always some degree of irregularities. The more aggressive, the more rippling. Now, luckily in the love handles, the rippling is incredibly small, whereas in the abdomen, it's much higher. So what is our recommendations? This is a synopsis. So your breasts, we want to remove and replace, change size, possibly change type.
Correct, yes.
And do an anchor reduction. Your final size is TBD.
Okay.
To be determined. Your abdomen, lose the weight you have left to lose.
Okay.
And then we have to reevaluate. And then you will have to make a decision. Do I want to just live with it? Or do I have enough loose skin where it warrants a tummy tuck? And if so, then will I be okay with the exchange of the incision?
Okay.
Your love handles, liposuction. Okay? Now I would go, all right, do you have any questions? Your lecture is finished.
How long would I expect with the reduction before I had to have another surgery?
Hopefully never. I mean, the reduction, listen, part of the reason why you have it is, A, you have large implants.
Okay.
So the implants don't change. And the other is over time, you gain some weight. So I'm sure when you had them when you were in your 20s, you were maybe in the 130s, and now you got up to the 160s.
I was in the 120s.
Okay. Okay. So you got to, if you gain a tremendous amount of weight, the breast tissue portion will alter. But assuming you stay stable,
okay,
you should be good to go.
Oh. Thank you so much.
Yeah.
So I've never had a consult like this before. I have had the quick and dirty consult where I was in and out in just a few minutes. They didn't tell me anything. They said, yes, sure. We'll do a lift, a reduction with an implant, and we'll give you liposuction as well, and you'll be fine.
Was the doctor the one who gave you the consult or his office manager?
Both. Yeah. And they were very concerned about me getting good insurance because they wanted to bill my insurance for some of it.
So and you went to Mexico to do that, or was that a reputable place?
That was in Beverly Hills.
Okay. Well, that's my neighbors. So this is why this is very useful, because you actually have a point of reference. Sometimes patients don't know any better. It's their first consult and they've never been to another one. You actually have the vantage point of having several different kinds. And again, I'm going to reiterate, this isn't because you and I are on the radio. It's because this is what we do all the time. I mean, this was a 40-minute consult and I was, blasting through it. So when I say it takes an hour, it takes an hour. There's no way to accelerate this process. Souffle takes, 30 minutes. There's no way around it. So I think that the fact that you have a point of reference is very interesting. Anything else that was different? Did you hear the same information?
I didn't hear any of this information that you told me today. It was just kind of, they wanted to get me in and book me for surgery. And I didn't know what questions to ask. That's why I haven't done it yet. And I've been kind of checking with different friends that are seeing different doctors and landed here. And finally, I'm hearing the truth about what will happen.
Okay, good. I think that's the key thing is I didn't know what to ask. And so you got to go on, like, for example, we have a Beauty After Baby, for example. It's beautyafterbaby.com. And I created that so that you have a downloadable PDF file so that you can take it with you wherever you go to ask questions. Because I think that what it all comes down to is if you don't ask, they won't tell. So it's on you to ask.
I never would have thought, one of the very striking points to me is I think anyone would have probably given me liposuction without making a real recommendation. But the part where you said that someone other than the doctor might be doing the stitching.
No,
that's very scary to me because the scarring is really important.
Okay, so and again, it's not because I'm just trying to say something. Just ask. Yeah. When you ask the doctor point blank to his eye, are you going to close everything? You're going to see a stutter, and you just say, well, most of it or whatever. And it's just the truth because the closing part is very time consuming. And the truth is that after 5-6 hours, you're tired. And so if you can get somebody else to come help you, you will. And about the liposuction. Liposuction is the #1 procedure done in America. It's being done by everyone and everywhere, by cosmetic surgeons, OBGYNs, et cetera, et cetera. The problem is that, on Instagram, for example, with the fat transfer to the butt, liposuction's, it's at an all-time high. No one ever tells you what these people look like in a year or two and what happens to their loose and irregular skin. I only get to hear about that when they come in and ask me to fix it. So if we don't have a real conversation, you are a different candidate than, say, you're the version of you that was 20. Maybe then you needed it. So I think it's really, I'm glad that you are able to at least share with everyone that you did have varying degrees of experience. And that really makes it very, very helpful.
And I'm very glad I landed here because I was considering, I wanted to take the fat in my abdomen and put some in my butt and all of that. But now it seems like it would
Yeah,
be
it's
a ridiculous thing to do.
Yeah, well, it's you have to proceed with caution. Again, I'm not here to judge anyone or anything. I'm not here to say who's right or who's wrong. I'm just saying at the end of the day, the only person that can ultimately make these decisions is going to be you and you and you only. And again, you said it. If you don't know what to ask, you won't know what you don't know. And I think that's really important. Well, again, I really appreciate you coming in today, and hopefully everyone found that to be very informative.
Thank you so much.
If you loved Plastic Surgery Uncensored, and I'm sure you did, I don't even want to say if, we would love to get your feedback. If you enjoyed and found our podcast helpful, tell us why. Give us the review and subscribe on your favorite podcast platform. We can be found on Apple Podcasts, Google Podcasts, Spotify, iHeart, or you can go directly to revolverpodcast.com. If you have a topic you would like us to talk about, then please reach out to us on Facebook, Roddy Raban, Instagram at Dr. Roddy Raban, or RoddyRaban.com. You are listening to Plastic Surgery Uncensored with Dr. Roddy Raban on Revolver Podcast.